Hello everybody, my name is Carly Vans and today I'll be presenting on topic A. So topic A gives us Sam. He's an 11-year-old boy with fatigue, decreased interest in sports, a concern of being a target for bullying, and excessive eating. His social and family history include that he lives with both parents and 2 older siblings. His mother has a history of obesity and is currently prescribed a GLP-1 receptor agonist for weight management. The family reports limited physical activity and increased screen time, and the patient has expressed feeling isolated and teased by peers, contributing to his emotional eating. His vital signs are a temperature of 36.5 degrees Celsius, his heart rate is 90, his respiration rate is 22, and his height is 132 centimeters, and he has a weight of 52 kilograms, which makes his BMI 29.8, which is the 128th percentile. So, our diagnosis that we're going to give this patient is obesity. Obesity is an increase in adipose tissue or an increase in body fat mass. And in children, BMI greater than the 95th percentile is consistent with obesity. So, organs and hormones that help regulate metabolism and appetite, we can start with our hypothalamus. Our hypothalamus receives signals from our small intestine, our large intestine, our pancreas, and our adipose tissue. And it regulates how much we eat and how much we store. It also uses the arcuate nucleus, or the arc, to balance 2 neuron sets. We have our orexigenics, which increase our appetite, stimulate eating, and decreases our metabolism, which would be like our ghrelins. Or we have our anorexigenics, which decrease our appetite, inhibit our eating, and increases metabolism. We also have our pancreas, which produces insulin, which is an orexinogenic, which helps with glucose metabolism, glycogen, and lipid storage. And then we also have our adipose tissue, which produces leptin. Leptin is an appetite suppressing hormone, and we'll get to more on leptin here in a little bit. So when we look at the pathophysiology of hormonal and metabolic changes in obesity, we can start with our white adipose tissue. In obesity, we have an increase of white adipose tissue, which increases our secretion of adipokines. This contributes to the dysfunction in regulation of hunger, satisfaction, and energy. We also have adiponectin, which increases our energy expenditure. It sensitizes insulin, and it works as a pro-inflammatory. But when we have obesity, we have a decrease in our adiponectin. So we have gluconeogenesis, insulin resistance, inflammation, and we have a decrease of our skeletal muscles reuptaking glucose. We also have an increase of endocannabinoids, which are unsaturated essential fatty acids. This causes an increase in appetite and white adipose tissue and lipogenesis. We also see some effects from our angiotensin II coming out of our adipose tissue. It promotes lipogenesis, it gives oxidative stress, inflammation, and insulin resistance. We also see that obesity is associated with a decrease of plasma ghrelin. So that is associated with increase in food intake, fat storage, inhibiting insulin, stimulating glucagon, and stimulating lipogenesis in white adipose tissue. Now, when we specifically look at insulin resistance and leptin dysregulation, according to our textbook, the mechanisms of insulin resistance are unclear, but it's associated with hyperlipidemia, increased fat storage, macrophages and inflammation, and alteration in adipokines. And our insulin resistance contributes to hyperinsulinemia, hyperglycemia, and predisposition to type 2 diabetes. We also find that retinol-binding protein 4 is an adipokine that contributes to insulin resistance. With leptin dysregulation, we have the way that leptin works is it both suppresses appetite and increases our food intake, which increases or decreases our energy storage based on what the body needs at that time. As our number of adipocytes increases, our leptin also increases until we get to a point that it's so increased that it's ineffective at decreasing our appetite and our energy use, which is known as leptin resistance. This contributes to overeating, weight gain, hyperglycemia, hyperinsulinemia, hyperlipidemia, and a pro-inflammatory state. So some laboratory findings that might be abnormal in this condition. If we were to draw a glucose and A1C, we would see that they are abnormal because of insulin resistance, increased gluconeogenesis, and increased lipogenesis. If we drew a fasting lipid profile, we would find increased LDL and triglycerides and decreased HDL due to increased lipogenesis and hyperlipidemia. Also, if we drew a CRP, we would see that that is abnormal because we have so much inflammation going on in the body as well. So treatment options and prevention strategies for this patient would include correcting our metabolic abnormalities and really talking about diet and exercise. And this doesn't mean fad diets. This means we have an 11-year-old boy who really needs help with nutrition. He may not know good and bad nutrition. He may be a picky eater. We have to find a diet that an 11-year-old boy can stick to and not give up. I also believe this patient could benefit from psychotherapy. He's struggling with bullying. He's emotional eating. He has a decreased interest in sports. It might be a good thing for this patient to speak to somebody about everything that's going on in his life. Now, when we specifically look at GLP-1s, we see that his mother's on them, so I think we should address them. These control postprandial glucose levels by 4 mechanisms. The first is to promote glucose-dependent insulin secretion. The second is to inhibit glucagon synthesis. The third is to promote hepatic glucose secretion. And the fourth is to delay gastric emptying. And all of these mechanisms work together to basically tell the brain we are going to decrease our food intake, and it decreases that addictive food behavior. It also increases our beta cell mass. So beta cell, that's where our insulin comes from in the pancreas. So it replenishes our intracellular stores of insulin. So potential complications if this is left untreated, obesity is the 5th leading cause of death worldwide, and it also contributes to cardiovascular disease, cancer, and type 2 diabetes, which are 3 of the leading causes of death in the United States. But other things this can contribute to are hypertension, stroke, hyperlipidemia, gallstones, GI reflux, chronic kidney disease, obstructive sleep apnea, asthma, hernias, and so many others. So this really could affect this patient systemically.